Hello everyone and welcome back to Medi Notes from Medicos. The topic that we're going to study about is about hepatitis B from microbiology that comes under the section of hepatobiliary infections. So the objectives are introduction, morphology, antigenic diversity, viral genome, occupational risk, transmission, pathogenesis, clinical features, the lab diagnosis, prophylaxis, immunization, post-exposure prophylaxis, treatment and case study. So we'll start with the introduction. The causative agent of hepatitis B is hepatitis B virus itself, and this virus actually belongs from the family of Hepanaviridae, which are primarily hepatotopic. The incubation period is 1 to 6 months, and the onset is always insidious. When we go to the morphology, we see that this is a DNA virus, and it has outer and inner core, and completely this at the whole is 42 nanometer. So the first thing that we see is over here. This portion is the spherical part. It is the first step and it is abundant, and this actually is at the whole as 27 nanometer. We have over here the uh, the HBs antigen, uh, and then we have the envelope, that is the lipid layer, which is also, this is the third portion of our um, morphology of the virus, in which that is a double walled spherical structure, and it measures 42 nanometer in diameter, and this is the one that completes the virus. This is also known as the Dane particle. Then we have another portion that is either filamentous or tubular, and this has a diameter of 22 nanometers, so it would either be filamentous or tubular. So next we'll be dealing with the antigenic diversity. We basically deal with three antigens over here in hepatitis B. One is HBsAg, the second is HBcAg, and third is HBeAg. So HBsAg is actually hepatitis B surface antigen, and it is further divided into ADW, ADR, AYW and AYR, in which the ADR is most prominent in South and East India and the Far East, and the AW is present in North and West India. So these are actually immunologically, they are very different, very distinct, but yet they are coded sometimes with the same gene. When we go to HPCAG, these are immunologically distinct, yet it is coded for the same gene. And HPAG has it is soluble, and it is non-particulate nucleoplasmid capsid protein. So now we'll be looking into the viral genome. It has it has many genomes, out of which three we are going to deal with. That is C gene, which is also the code for core antigen; S gene, the code for surface antigen; and P gene, which is the code for polymerase antigen. The next is, which are the occupations that are at risk of hepatitis B? Medical personnel, paramedical personnel, lab workers. This can be either by needle stick injury or sharp material disposals, etc. Surgeons and dentists, if they use sharp materials during their surgery or during their appointments in the dentist, during the appointments for the extraction of tooth, etc. Sex workers and barbers. Why barbers? Because they too use sharp instruments that might cause, like razor and all, that causes cuts. So we'll be dealing with the transmission. We have three modes of transmission. One is the perinatal transmission, and the sexual mode. So when we go for the parenteral modes, it can either be by shared syringes, it can either be by sharp items, endoscopes, through ear and nose piercing, tattooing, ritual circumcision, barbers and doctors who use sharp articles in surgical camps, or uh, when the diagnosis or the surgery equipments are not sterilized enough, and infection can also be occurred by direct contact if the skin has certain sorts of open lesions, for example cuts, etc. When we go to sexual modes, the partners who have the people who have multiple partners have the high probability of having hepatitis B, comparing to one who follows monogamous sexual practices. However, if the partner, even though is monogamous, is infected, then the chances of having hepatitis B increases. Artificial insemination and sex workers are also the cause of sexual modes. Perinatal modes is, it can either be congenital or it can be by vertical transmission. It is occurred usually during the birth time, and the placenta gets and the placenta opens up and it gets contact with the mother. Usually they don't be usually the babies are asymptomatic in nature. However, they would remain carriers for the entire life, and it is more safer if carrier mothers don't breastfeed the babies until and unless it's required. Next is the pathogenesis. Actually, this is immune mediated pathogenesis. Here, what happens is once the transmission of the HPV virus occurs in a human body, it replicates within the hepatocytes, and hepatocytes they carry the viral antigens, and this gets subjected to antibody dependent NK cells and also the cytotoxic T cell attack. So, if the presence of adequate immune response occurs, the hepatitis B infection takes place. But in cases like absence of adequate immune responses, the disease turns into asymptomatic carriers. Now, what are the clinical features? The clinical features presented by a patient would be persistent fatigue. They might have not so prominent fever, loss of appetite, extrahepatic complications like arthralgia, urticaria, and rarely polyarteritis or glomerulonephritis may occur, abdominal pain, nausea, vomiting, yellowing of the skin, and sclera. Next is the lab diagnosis. So when we go for lab diagnosis, what are we going to check? We're going to detect the viral markers over here. So we have three viral markers, as we say, because we have the antigen variants over there, that is HBsAg, HBcAg, and HBeAg. So when we go for HBsAg, it is the first marker that appears after in blood after the infection. When it's no longer detected, the anti-HBs, that is the protective antibody, it appears and they remain for longer time. When we go to HBc Ag, it's not demonstrated in the circulation. Anti-HBc body, it appears after 2 weeks of HBsAg appearance in the serum, and it is the earliest antibody marker that is seen in blood. Initially, anti-HBC would predominate predominantly IgM, but after the 6 months, mainly IgG would be present. So, this helps in the distinction whether the infection that has occurred is recent or it is remote. Now we'll be going for HBeAg. So this would be the indicator of active hepatic viral infection. So it appears along with HBsAg, and if you see it anti-HBe, this shows that the infection is low. Now we'll be going for the LFT test. In that we'll be seeing that the serum bilirubin would be increased level, and liver enzymes also would be elevated. Now, we can also find that HBV DNA present in our blood circulation. So this would be an indicator of the viral replication and infectivity. We'll also be going for the molecular methods. We'll be going for DNA hybridization and the PCR method. Now we'll be looking into the prophylaxis. In prophylaxis, we have to follow safe sex practices. That is, we have to avoid promiscuous sex. Then we have to give health education. We have to use disposable syringes and needles. That is, no sharing of intravenous, no sharing of the same syringe for patients, or we have to stop the injectable drug abuse too. And we have to screen the blood, semen, or the organ donor before we use it on a patient. What is the immunization available for hepatitis B? We have three sorts of immunization. One is the passive immunization, the active immunization, and the combined immunization. So the passive immunization is by the hyperimmune hepatitis B immunoglobulin, that is HBIG. We give it in intramuscular administration, and the dose that we provide is 300 to 500 international units. And this vaccination is given post exposure to the infection. The active immunization is by the hepatitis B vaccine. This is given with alum and adjuvant to the intramuscular into the deltoid. In infants, we give it to the anterolateral aspect of the thigh. So three doses are given over here at 0, 1, and 6 months. So the booster dose, it's required only if the titer is less than 10 international units, and babies are supposed to receive 0.5 ml of the vaccine within 24 hours of the birth. In combined immunization, it is actually for immunosuppressed babies born to carrier mothers. And babies, they get single dose of HBIG of 0.5 ml dose intramuscularly within 15 hours of birth, that is first dose. Now, what are the post exposure prophylaxis? If the patient or if the individual who has been exposed to the virus is unvaccinated, we would be giving them a combination immunization of HBIG vaccine along with hepatitis B vaccine. It is a mandatory rule. So, what is the doses? We would be giving HBIG dose. Along with that, we'll be giving a single dose of zero point 0.6, 0.06 ml per kg after the exposure. But however, we would be continuing a full course of the hepatitis B vaccine. In immunocompromised individuals, after the regimen, we would be giving them the booster dose. And individuals with undetectable antibodies, that is less than 1:10 ratio, are also requested or advised to undergo repeat vaccination in order to prevent the re-exposure of the hepatitis B. What is the treatment? Basically, because it is a virus, we don't have a specific treatment, but we provide in chronic hepatitis entavir, tenofovir diproxil fumarate, and peg interferon alone, or we'll be giving them in combination with antiviral antigens like lamivudine or and famciclovir. In chronic hepatitis B in adults, we give it's recommended to give tenofovir alafenamide, and spontaneous resolution may occur in carrier state and no specific treatment though. Now let's go to the case study. So, a 35-year-old man presents to the OPD of emergency department due to abdominal pain and malaise. He also reports yellowing of his skin. Medical history is non-contributory. Social history is notable for intravenous drug use. So we can see over here abdominal pain and malaise, yellowing of his skin, social history notable for intravenous drug use, and having sexual multiple partner. Physical examination remarkable for right upper quadrant tenderness, generalized jaundice, scleral icterus. Laboratory diagnosis demonstrate presence of HBsAg and significantly elevated IgM anti-HBc and HBAg. This all indicates, these symptoms indicates clearly about hepatitis B. So now this is given as a detailed question. So how about if this much details is not given? Like for example, in this case, a 40-year-old woman who had received multiple blood transfusion over the past 6 months presented herself with persistent fatigue, loss of appetite, nausea, vomiting, and abdominal pain for a duration of 10 days. She had a history of passing high-colored urine. Her LFTs showed elevated serum bilirubin and liver enzymes. So what are the catchy points over here that would help you diagnose that it is a hepatitis B virus infection? We can see over here this women over here have undergone multiple blood transfusion over the past 6 months. She presented herself with persistent fatigue, loss of appetite, nausea, vomiting, and not to forget the abdominal pain for the duration of 10 days. The most catchy point over is her multiple blood transfusion. So multiple blood transfusion can have a differential diagnosis of HIV also, but since we have an abdominal pain for the duration of 10 days, and we also having a history of passing high colored urine, which is a case of jaundice obviously, and her LFT shows elevated serum bilirubin and liver enzymes. This is one of the lab diagnoses that we have undergone. So this is a case of hepatitis B. So that was for today's video. I hope you like this video. If you like this video, don't forget to like, share, and subscribe to the channel. We'll be coming with more videos. Till then, stay tuned. Happy learning.